Hi. Now I would like to introduce Dr. Dominic Roca. He is an MD and PhD. Dr. Roca is the director of the Connecticut Center for Sleep Medicine in Stamford, Connecticut. After receiving his MD PhD degree from Downstate Medical School in Brooklyn, New York, he completed his sleep fellowship at Harvard University. His PhD work involved the study of effects of caffeine-like drugs on brain cells. He is board certified in internal medicine, pulmonary, critical care, allergy and immunology, and sleep medicine. Welcome, Dr. Roca.
So is there a laser pointer? Does this come on? Unfortunately, I like to walk around, but I think I'll break my ankle doing this. No, that didn't work. I had to show that. Okay, so actually I made a couple of changes I have to remember. So I'm going to talk about some of the drugs, and then I'm going to talk about some new drugs coming down the pike, talk a little bit about efficacy, and then wrap it up. And I want to start off by telling you I'm going to be giving you my perspective on treating patients. It is not necessarily the recommendations of the American Academy of Sleep Medicine, and I'll actually call on Dr. Ahmed to comment and see if he does things differently. So, as Dr. Ahmed was talking, there's two different types of narcolepsy. It's type 1, where you have cataplexy, and type 2, where you don't. And we know a lot more about type 1 than type 2. And unfortunately, in my opinion, type 2 is a bit of a wastebasket terminology. And there's a lot of people that are type 2 narcoleptics, and if they sit at a table and talk to each other, their symptoms can be very different. As Dr. Ahmed alluded to, the testing is not perfect. It's not like diabetes, yes, you have it or no, you don't. You're pregnant, yes or no. Or you have high blood pressure. The testing is really not great. So this is a study done by Mary Carskadden. Mary Carskadden is one of the founders of the MSLT, which is the test that we use for narcolepsy. And she took high school students, and this is many years ago, and looked at how fast that they fall asleep. And we should keep in mind that on average, it'll be about 10 minutes. And she found that many of the high school students were falling asleep rather quickly. Not necessarily under 5 minutes, but certainly under 8 minutes. And her conclusion was that there's a significant number of high school students that feel that they're normal that are falling in the range of narcoleptics. And so the testing is not perfect. And you have to keep this in mind when you're talking to your doctors and you're evaluating family members for narcolepsy. It really is a combination of what you feel is going on and what your doctor feels is going on, and put that together with the testing. It's not a pathognomonic process where, boom, your test shows this, you have narcolepsy. Again, the persons who have cataplexy, it's a different category. You have cataplexy, you have narcolepsy. So I'm going to start off by talking about modafinil, and then I'll talk a little bit about amphetamines and Xyrem. And these are medications that we use for sleepiness. So modafinil was actually discovered in the 1980s. And what they typically do when they're trying to discover drugs is if you have a drug that you know works, you make small changes, change molecules here or there, and then inject it into animals and then determine, hey, did this work? And what they found with modafinil is that, yes, it kept the animals awake, but there was a difference. With amphetamines, you're awake and you're moving around a lot, sort of like what I'm doing here, up and down. Whereas with modafinil, the animals were awake, but they weren't having that hyperactivity. So there was a little bit of a difference. Now, many of you are familiar with armodafinil and modafinil. And basically, keep in mind that when you use modafinil, it has armodafinil in it. Modafinil is a mixture of two, what we call isomers or chimeras, mirror images. And I know it's being subsidized by a drug company, but it's a very clever way of maintaining patent, because you can now isolate one of the isomers, and now you have a patent that's extended. So there are some differences in the way the two isomers work. The R isomer, or R-modafinil, lasts a little bit longer. But overall, the peak effects in about 2 or 4 hours, half-life is about 15 hours, which means when you take a dose of modafinil or you take a dose of R-modafinil in the morning, you still have it in your system the next day. This was a study looking at modafinil versus armodafinil, and bottom line is what they found was that the armodafinil seemed to last longer, the effects seemed to last longer than modafinil. So what are the side effects of modafinil? The biggest one that's oftentimes a problem in the early stages of taking the medication are headaches. There are a number of side effects that are similar with all the stimulants: anxiety, irritability, insomnia. And with almost any pharmaceutical agent, you can cause rash. At high doses, you can have some of the effects that you see in amphetamines, which is increased blood pressure and increased heart rate, but far less than you see with the amphetamines. Modafinil is a pretty safe drug, but there have been reports of it being abused and being used to improve productivity. So people who don't have narcolepsy are looking to seek to get modafinil because it enables them to do more. However, in terms of abuse potential, if you compare it to agents like cocaine and stimulants, it's far less of a problem. In Connecticut, before it lost patent, you were able to give samples of modafinil. So that's how safe it was, or is. The mechanism of action was controversial for a while, but most people do feel that it's working mainly through the dopamine receptors and by increasing dopamine activity in the brain. I'd like to switch gears a little bit and talk about amphetamines. The two main classes I like to talk about are Adderall and Ritalin. There are derivatives of Ritalin, Focalin, Concerta, Metadate, and derivatives of Adderall like Vyvanse, Dexedrine. The amphetamine's half-life is really variable because it's different preparations. You have medications that are fast-acting and you have medications that are long-acting. The peak effects, therefore, are very variable, from 30 minutes to 2 hours. Most of them are metabolized by the liver. The side effects of amphetamines are much more than modafinil. You have cardiac side effects, particularly blood pressure, palpitations. You can get irregular rhythms. If you are running with a high heart rate, time and time again after you see your doctors, there can be effects, permanent effects on the heart, resulting in something called a cardiomyopathy. The thing that I couldn't find any data on is if a patient comes to me and I start them on amphetamines, what's the likelihood that they become addicted to that drug? I couldn't really find anything on that. But in my personal experience, I rarely see that. Any patient that I've had that's developed an addiction, basically they had addictive issues coming into the arrangement with me and the treatment. So I haven't found that problem. Now, obviously, if you have someone on Adderall every single day and you take it away, they're going to be really sleepy. In terms of addictive potential, amphetamines are down here. They are addictive. but not nearly in the same league as alcohol and nicotine. And modafinil isn't on this. The mechanism of amphetamines are broader than modafinil. Modafinil, as I told you, is more dopamine. Amphetamines are dopamine, norepinephrine. So it gives you more of a buzz. It gives you more of an energy impact than the modafinil does. Xyrem. Xyrem, as mentioned, is a medication for cataplexy, but it also has been shown to improve alertness. It was studied in the 1960s, and it was used as an anesthetic in Europe for many years. Then, unfortunately, it came under notoriety as a rave drug and a date rape drug because it's a colorless, odorless agent. In 2002, however, it was approved for treatment of narcolepsy. It's very fast on and fast off agent. One of the caveats to it is that you should wait and eat at least 2 hours before taking the medication because it can be absorbed and you minimize the effects of the medication. Xyrem side effects. Xyrem is a very carefully controlled agent, as many of you know. It can cause respiratory depression, and if you combine it with other agents, sleeping pills, alcohol, it can potentially cause death. So it's something that you have to use with a great deal of care. So this was a study looking at addictive potentials of GABA hydroxybutyrate or Xyrem, and you can get animals to do things because they like the effects of Xyrem. And in humans, there are properties also that encourage abuse. Interestingly, Xyrem has a receptor. GABA hydroxybutyrate is a receptor that's in the brain. So it is a natural product as a transmitter in the brain. And so it binds to its own receptor. It can also bind to another receptor, GABA receptor. Both of these receptors quiet the brain, decrease activity. And if you look at brain waves of people on Xyrem, it's like anesthesia. You have deeper, slower brain waves, deeper sleep. I'm going to switch gears and talk a little bit about cataplexy treatments. And again, we have Xyrem as a treatment for cataplexy. And then you have the antidepressants, which before Xyrem, this is what we were typically using. We were using medications called tricyclics and also antidepressants that block serotonin and norepinephrine uptake, venlafaxine or Effexor. The tricyclics are rarely used nowadays because they do have significant side effects. More often, if the patient cannot take or tolerate Xyrem, then we'll use venlafaxine or Effexor. And we find that it works quite well. It does have some side effects, but in general, it's pretty well tolerated. A new drug that is coming down the pike is solriamfetol, which is a jazz drug that has, in my opinion, at the meetings, at the last meeting, it seemed to work very similar to a lot of the amphetamines. Pitolisant, somebody was talking about, you were talking about histamine before. This is actually a histamine agonist. So it works on the brain to stimulate alertness. But you have to keep in mind, this is, you can't give histamine to someone in their body because that's obviously going to cause itching and allergy type symptoms. So these are medications that enhance histamine activity in the brain. They're not actually histamine. So for a brief summary for this part of my lecture, for sleepiness, we use modafinil or armodafinil. We use amphetamines, Xyrem. For cataplexy, we use Xyrem and venlafaxine. That's typically what we use in our in our lab or in our offices. So I was going to stop here and take questions, but I think I'm just going to go through and then stop at the end, and then we'll take questions at that point in time. So I'm going to talk to you a little bit about the studies that showed how these medications worked. So before we talk about additional drugs, I do want to come back to behavioral things that we can do to perhaps help the treatment of narcoleptics. And one particular thing is naps. Naps can help people feel better. As Dr. Ahmed had mentioned, naps will oftentimes, in the classic narcoleptic, you will feel some improvement after the nap. Unfortunately, when you look at the data, the benefits are short-lived. So if you take an hour nap, a narcoleptic may feel pretty good for half an hour, 45 minutes, maybe even an hour, and then after that, they start to lose the benefits of that nap. Whereas a person who does not have narcolepsy, the benefit of naps will last longer. But we always try to push patients to take naps if they can. So this is a study where they compared modafinil versus amphetamines, and this is something that you'll see time and time again. Modafinil is not as potent an agent as the amphetamines. The amphetamines will give you more bang for your buck in terms of alertness, but there's more side effects. This was a study where they looked at modafinil versus caffeine. And they found that modafinil, 200 to 400 milligrams, was actually not much better than caffeine. But you have to keep in mind, caffeine 600 milligrams, that's a lot of coffee in one shot. And so caffeine can help, but its half-life is rather short, so you have a very dramatic peak effect, and then you crash, whereas modafinil will last a lot longer. The ARCI scale is a scale that looks at sort of addictive potential of medications. And again, here's the amphetamines, and then you have caffeine and modafinil far lower. So there's far less addictive potential. It's more than placebo, but it's not nearly as great as you see with the amphetamines. So what about modafinil versus amphetamines in older individuals? And the same thing, the same message. Amphetamines are more potent than modafinil. Now this is a really important slide. This is a compilation slide put together by Mittler. And let me just take you through it a little bit. So these bars represent the patient before drugs, and this is after the medication. And we're looking at percent normal sleep latency. In other words, how fast do you fall asleep compared to a normal person? And the first point I want to make, in all these situations, even with the medications, and Dr. Ahmed had pointed this out in one of his slides, and I think it's a really crucial thing, is that even with the medications, the narcoleptics were not as alert as the normals. And I think this is a really important point, because it's a battle that I frequently have with my patients, in that when they first come to see me and they first start on treatment, it's like nirvana. It's fantastic. They feel great. They feel better than they have in years. But then 6 months come down, or a year comes down, and now all of a sudden, not so much. And so what I try to tell patients is this, and again, this is just my philosophy. It is not the philosophy of the American Academy of Sleep Medicine, and not the philosophy of every doctor. I tell patients this: the medications are there for two purposes. One, to keep you safe, so you're not going to drive your car into a tree. Two, to allow you to be productive, to allow you to have a life so you can be productive, you can go to work, you can go to school, so that you can be productive. But the medication is not to make you a super person. The medication is not made for you to get up at 8 o'clock in the morning and work till 11 o'clock at night. That's not what the medications are for. And if you try to do that day after day after day, you'll get yourself into trouble. because you'll start seeking more and more medication. You have to take a step back and you have to look at your overall health. And if that means not taking 18 credits when you're in college, then that's what you need to do. You're in this for a long game. This is not just a sprint. And so using 3 times as much medication as you perhaps should because you have to get or you want to achieve a certain goal will hurt you in the end. So keep in mind, even with the medications, most narcoleptics are not as awake as a normal person. And if you try to always achieve that, you may get yourself into trouble. This is a study where, I thought this was a great study. They compared Xyrem, Modafinil, and the combination. So these are all patients on Modafinil in the beginning. And then what happens is they take the Modafinil away in the control group. So you see, boom, they get much sleepier. This group here is staying on the Modafinil, so there's really no difference. This group here is just, they're on the Modafinil here, and now they get switched over to Xyrem. And there's actually a slight improvement. And then this group is the Modafinil plus the Xyrem. So Xyrem alone had alerting effects. And there are some physicians that will treat patients who have daytime sleepiness just with Xyrem, because the patients don't feel that edginess, that nervousness, and they tend to like that they feel a little bit more normal. This is solriamfetol. This is the new medication that Jazz is coming out with. And this was looking at ability to stay awake. And what you see is here's you have the control, and then this is with the medication. And there's definitely an improvement in alertness with solriamfetol. This is pitolisant. Pitolisant is the histamine. This is the agent that increases histamine in the brain. And they compared pitolisant to modafinil to placebo. I think this, you probably can't see it. But placebo, the MWT, maintenance of wakefulness test, can you stay awake if I put you in a situation that's kind of sleepy? And in the placebo group, they were falling asleep in about 8 minutes. In the pitolisant group, it improved to about 9.7 minutes, but modafinil, it improved significantly more to 15 minutes. I tend to think of modafinil as being a milder agent, and in this one study, pitolisant was less potent. Now, that's only one study. I haven't seen all the data on pitolisant. Takeda is coming out with an orexin. They're studying an orexin agonist. Then they have some animal studies showing some nice, promising data. I've not seen human studies. I don't know if you've seen anything. Okay, so the next 3 scenarios, I'm going to tell you what I do when patients come to see me and how I treat them. This is my style. So if the patient comes to me and they have mild daytime sleepiness, assuming they did the testing is positive. So they have mild daytime sleepiness. They've been able to get by, but they may need like 4 naps in a day, and they've been struggling. So I'll encourage them to continue taking at least 2 naps. Now, sometimes people can't take long naps, but for many narcoleptics, they may get some benefit out of a 20-minute nap. And so I try to encourage people to take naps, to continue taking naps. I will give them a prescription for modafinil, 100 milligram tabs, and I'll say, okay, start off with half a tab a day, and then every couple of days, if you think it's not working, if you're still, again, your goal is you got to be productive in school, you can't be falling asleep driving, okay? It's not meant to keep you awake till 11 o'clock at night. So with that in mind, I'll give them the flexibility to taper up the medications and then come and see me in a couple of weeks, and we say, okay, what dose works for you? And then we start them at that dose. Again, this is a unique thing that I try to do, and the American Academy of Sleep Medicine actually advises against it. They say you should not use drug holidays. Part of my background, as Tammy was mentioned, is I have a PhD in neuropharmacology. And so I've just seen so many drugs, people become tolerant to the medications over time. So my feeling and what I stress is don't take the drug every day. Now, obviously, there's going to be times when you have to. If you're in final exams, you're going to have to take the drug every day. If you're a single mom and you're taking care of kids, you have to take the drug every day. But if you can avoid it, I ask the patients to focus on taking the drug maybe 4 times a week, if that's possible. So this would be a patient who has mild daytime sleepiness. When patients start having more moderate sleepiness, then I tend to add in a short-acting amphetamine, usually in the morning with armodafinil, and then sometimes a short-acting agent in the afternoon. And then we'll talk about using Xyrem. And again, I will try to emphasize that I think it's best if you don't take the medication every day. And if it's you're going into the summer and you're going to have a month where you're really going to be focusing on activities that you can be a little bit sleepy and take more naps, then I will stress the patients do that. Again, just my style. For severe sleepiness, I tend to go mainly with the amphetamines because at that point in time, the armodafinil is usually not as effective. So it'll be short-acting amphetamines and long-acting amphetamines, and then almost always they'll be on Xyrem. And again, I will try to ask them to limit the use of the medications. For cataplexy, if it's mild, some patients, even though it's not supposed to, but I find in some patients the stimulants are enough to get them by if their cataplexy is mild and infrequent. However, if it's more severe, we'll always start with Xyrem first. I think it's a well-tolerated drug for most people, and it doesn't give them the edginess and it doesn't affect their emotions as much as some of the other drugs. However, if they can't tolerate Xyrem, then I will go to a medication like venlafaxine. So the first thing I try to tell patients when they come to see me is that, look, we want to make you feel better, we want to make you feel more productive, but at the same time, I want to keep you safe. This is a disease where people are going to have it for years. It's not for weeks, not for months. It's going to be for a long period of time. And so what you're doing now can impact how efficacious these medications are going to be later on. So I'll take some questions now.
Thank you very much, Dr. Roca.
Actually, before we take questions, I wanted to know if Dr. Ahmed has any comments just on treatment.
Yeah. So regarding the naps, I agree. I encourage taking naps all the time. Every patient who has narcolepsy, I encourage taking naps. I find that strategic napping is key. If you nap because you have to nap, you're going to tend to nap much longer. But if you nap because you schedule the nap before you actually feel that you need it, you actually are able to maintain about 15-20 minutes or even 30-minute period where you're actually able to stay, nap and then feel refreshed. But many times people with narcolepsy, they wait until they actually feel sleepy, then they take a nap and they end up napping for an hour or more, which is not productive. So strategic napping is important, scheduled naps before you actually feel sleepy. In terms of medications, I agree a lot with what Dr. Roca actually mentioned. I do start with Xyrem if the person has cataplexy of any type. I just start with Xyrem. It's the only FDA-approved medication to treat cataplexy. I start with that. If they can't tolerate it, I go to the other antidepressants like venlafaxine or protriptyline. As Dr. Roca also mentioned, I would also start with the modafinils for daytime sleepiness. But napping is key. I agree.
Okay. Questions? They come to the back of the room.
Hi. I was wondering if you can talk at all about Xyrem and psychosis and seizures that does not involve abuse.
So I have had a few patients, and I'm actually going to frequently ask Dr. Ahmed because might as well get the price of two for the price of one here. There have been reports of anxiety and mood issues in patients that are on Xyrem. Even though the medication is a nighttime drug, I have had some patients complain, and I've had some patients that had to stop the medication. I have not had anybody had full-blown psychosis. There were reports of seizures in association with Xyrem. However, I'm not convinced that it was definitely promoting the seizures. But there are reports of seizures. I've not had any experiences with patients having seizures. I can just tell you that they have been reported. Mood issues and mood changes following the Xyrem is something that I have had patients experience. Not common, but I have had it. I've not had any have full-blown psychoses. Do you have anything to add?
Yeah.
Why don't you stay? Why don't you stay here?
So for psychosis, generally, if you have a lot of hallucinations beforehand, I find that taking Xyrem can, it's not officially mentioned, but it can actually, those patients do tend to be worse. The psychotic episodes do tend to be worse. Sometimes, but then if you have to consistently take the Xyrem, then it actually stabilizes that psychotic behavior. But full-blown psychosis, I actually haven't seen, unless they have a preceding or history of having psychotic episodes. So Xyrem promoting or producing it, like as a new symptom, then no. In terms of psychosis. In terms of seizures, I actually, I trained in epilepsy as well. So theoretically, Xyrem can produce seizures during sleep, not during wake, but during sleep. Xyrem actually increases slow wave sleep. Slow wave sleep is very rhythmic sleep. When you increase rhythm in the brain, you actually support seizure evolution or seizure progression. But it doesn't actually cause seizures. But if you already have a history of seizures, you can potentially make it worse by taking Xyrem at bedtime. But it's not clearly reported. There are some reports, but it shouldn't worsen your seizures during the daytime.
Hi, I'm Dr. Priya Prashad. I'm a sleep medicine specialist, pediatric and adult at Westchester Medical Center, and my treatment style is very similar to both you guys. And what I struggle with, though, is getting my adult and pediatric patients approved for Modafinil and Armodafinil, especially my Medicaid patients. They've gone through the stepwise therapy, the traditional stimulants, and I just wonder if you guys have any tips for me or other options that you use to get those patients the treatment that they need.
I actually have not had problems getting Modafinil or Armodafinil. I mean, when I say I haven't had problems, I'm taking into account that filling out a prior authorization 4 times is not a problem. I mean that's just medicine these days. So, but in the end, I've almost always been able to get one of the drugs for the patients. I haven't really. Xyrem has been a little bit more of a problem, but I really haven't encountered that to the point where I cannot give the patient that medication. So I don't know. But
no, I agree.
Yeah.
Xyrem has been a problem. I believe the reps are working on fixing that problem and trying to get the Xyrem medication approved for most people, or as all people if possible. In terms of the prior authorizations of Armodafinil, you're right. I mean, you just have to do the paperwork, and it does. Sometimes you have to do, give them a trial of the amphetamines and say that they failed, if they did fail, and just to get Armodafinil, Modafinil. But yeah, it is hard, just prior authorization.
yeah, I mean, I've definitely done that. I've definitely given a patient a prescription for, 5 pills of Adderall, and I tell them, listen, just come back to see me and tell me it didn't work. Any police officers here? No. Yeah, I mean, I definitely had to play that game.
Okay. Let's see. I'll come back to you. Okay. All right. Okay.
actually, my daughter wasn't covered, the modafinil, until they were 17. So would you say we should be contacting the reps? Because we went through, and I have Blue Cross Blue Shield, and we went all the way up. You know, we go to CHOP, and they argued with them. They brought case studies. So would the rep be somebody who could get the modafinil covered?
The rep can't do that, but the rep can sort of give you some ideas. I'm surprised. I haven't encountered it. And with the private insurance, I mean, maybe they don't lie as much as I do. I don't know. I don't know. I mean, just say the patient started getting tachycardic and felt like they palpitations, they couldn't function in school. We gave them a sample, the patient tolerated it, and it's fine. The other thing is for those people who have a little bit of money, you can get modafinil for fairly inexpensive prices at Costco, just out of pocket. You can get, like for $40, you can get like a month's supply. So, I mean, for some people, you can do it that way too. But I haven't encountered that, and like I said, maybe I just lie a lot more. I don't know.
No, I was.
Hi, thank you. I have a 14-year-old daughter who was just diagnosed in June. She started taking Xyrem and Armodafinil in August. Going to your lecture here, I guess I'm concerned. Should I speak to her doctor about being so young and it being a lifelong diagnosis and treatment, that she should be taking it or not taking it every single day? I guess I'm worried now about that.
So, again, as I said, this is just my opinion. And it applies to many medications and treatments. So I'll just give you a completely unrelated example. So if I have an asthmatic who's on an inhaler and they've done well for 6 months and they're not having any asthma exacerbations and they're supposed to take the medication, twice a day, I will sometimes say, listen, let's try doing it let's do it once a day, and let's see how your pulmonary function test is, let's see how your exercise capacity is, and let's see how you do. As long as I'm watching closely, and when you have a mom who's coming up here to learn about this, obviously you're really attentive to all of this stuff. What's the downside to trying less medication and see how a person does? So what you're doing is what the textbooks say. It's not what I do. I just try to use the least amount of medication that gets the person functional and safe. Then it's just my opinion.
That's it.
Yeah. Okay. Dr. Megan, please. I think I would go back. Look, it's funny, and I think the society is changing, but you have to be with a treatment like this, and you have to be in partnership with your physician. It can't be a one-sided thing. It can't be like, oh, this is what you do, and then you walk out and you say, thank you very much. It's got to be, well, what about this and what about that? You have to have that. You have to have that. And if you can't have that relationship, well, then you need another doc.
I'm going to take one more question.
Hi, I have narcolepsy with cataplexy, and I have a question about modafinil and its if it has any sort of effects that we should be concerned about long-time use as far as the heart. You had mentioned that it can affect that and high blood pressure, and certainly you'd mentioned it was more of a side effect for the amphetamines, but if you could speak more to that and if there's anything.
So I think if you go to your physical exams and you're on the modafinil and your heart rate is good and your blood pressure is good, I wouldn't be concerned. I have had patients where they're coming to see me and their heart rate's 110, 120, and I get a little bit concerned. So that's my point, is if you're on getting physical exams and you're finding that there's some issues with your heart rate or you're getting frequent palpitations, I wouldn't necessarily accept that as, oh, it's just got to be that way. That might be someone who you need to change things up a little bit.
Thank you very much, Dr. Roca.